Good evening. I welcome you to this Indian College of Anesthesiologists ICA webinar dated 7th of June 2023. And the subject matter today is pro-con in cardiac anesthesia. So the scientific program contains 6 sections. Under each section, there are 2 speakers who will be speaking for and against a particular modality, and it will be moderated by one of our senior experienced erudite faculty from India. First one is TE and TTE. Second one is Milrinone versus Dobutamine, moderated by Selva Kumar. Dr. Rajesh Arya will be moderating the first 2 talks. The third one is PAC versus TEE. Dr. Kumar from Madurai will be moderating that. Then we have on-pump versus off-pump CABG. Dr. Kanagarajan from Chennai will be moderating that session. And we have IABP versus Impella. Dr. Poonam M from Delhi will be moderating that, those 2 pro and con sessions. And lastly, Dr. Raghu will be moderating the pro for DLT and pro for blockers, bronchial blockers. With this, I would like to start the session. I would like to invite Dr. Rajesh Arya to take over. Each of the speakers will speak for about approximately 5 minutes. So followed by the moderation by Dr. Rajesh Arya. If you have any questions, feel free to put it in the chat box. We'll answer it either at the end of the 2 talks or at the end of the whole session, depending upon the time availability. With that, I request Dr. Rajesh Arya, who is a pioneer in cardiac anesthesia from our country. He's the brain behind the Echo Library, which is running very successfully. Excellent images are there in that library. Please make use of that resource. With that, I request Dr. Rajesh Arya to take over and conduct the first part of the pro-con session.
Good evening, everyone. First of all, thank you, Dr. Murli and Indian College of Cardiac Anesthesia, to give me a chance to just observe. I think the speakers are experts. So moderation is a very moderate word for me. I think it's a healthy discussion, what we expect. And we have got Dr. Pavithra, who will be speaking on trans esophageal echo, and Dr. Satish will be speaking on transthoracic echo. If I see broadly, both the things are complementary to each other, but still, which is better in which condition, that is what we aim at this session. And I'm sure both the speakers will try to specify those things and giving importance to the things which are important for particular condition. And finally, let us see how the experts and Dr. Murli and other people participate and give their inputs to this. So I invite Dr. Pavithra to present the trans-esophageal echo. Dr. Pavithra, please.
Good evening, one and all. Today, I am going to talk about pros of transesophageal echocardiography in contrast with transthoracic echocardiography in critical care setup. First, let me briefly introduce what is TEE. TEE uses ultrasound waves to examine the heart and great vessels. There are 4 basic TEE rescue views that are all easy to obtain and helpful in determining the potential cause of cardiac arrest. TEE can provide valuable information quickly and at a low risk, therefore is a useful tool to improve outcomes and patient survival. TEE has become a very important and efficient technique in clinical practice. It is indicated in any case when TTE is inconclusive and in patients who are extremely difficult to be assessed using transthoracic echocardiography, such as post-operative patients and mechanically ventilated patients. The indications for TE in critical care setups include monitoring and evaluation of hemodynamic instability, patients with suspected endocarditis, pericardial effusion, evaluation of aortic dissection, complications of myocardial infarction such as left ventricular aneurysm, papillary muscle rupture leading to acute mitral regurgitation, hypoxemia and pulmonary thromboembolism, to detect the source of systemic emboli, evaluation of chest trauma, evaluation of heart transplant donors, and assessment of valvular functions. So these are the four basic rescue views in TE. The first shows transgastric mid-papillary short axis view, which helps us in assessing the left ventricular function. The second picture is mid-esophageal four-chamber view, in which we get a comprehensive view of all the four chambers along with IAS, IVS, tricuspid valve and mitral valve. The third is mid-esophageal two-chamber view. It focuses on left atrium, left ventricle with mitral valve and also visualizes left atrial appendage, which is the most common location of intracardiac thrombi. The fourth is mid-esophageal aortic long axis view. In this, in addition to left atrium, left ventricle, mitral valve, we also visualize left ventricular outflow tract and aortic valve. So there are certain conditions in which transthoracic echocardiography gives a suboptimal image and limits the success. The examples include patients who are on mechanical ventilation requiring a higher positive end pressure of more than 15 centimeter of water, and patients having inaccessible windows such as those with surgical dressings and drains, chest tubes, and thoracic or upper abdominal incision. Patients with pneumothorax, pneumopericardium, and subcutaneous emphysema also have a suboptimal TTE view. Patients having surgically induced fluid collections also have a suboptimal TT view. Inability to position the patient or patient to cooperate for respiratory maneuvers, obese patients and patients with severe chronic obstructive pulmonary disease also have a suboptimal TT views and thus are more which can be overcome using TE images. So we move ahead with pros of TE. TE is more sensitive in diagnosing infective endocarditis, especially involving tricuspid and mitral valves. Here is a picture showing the vegetation on the mitral valve, and this is a case of infective endocarditis. It is also helpful in diagnosing left atrial and left ventricular lesions due to its close proximity than TTE. TE is also advantageous in patients with morphological deformities impairing transthoracic echogenicity. It also helps in diagnosing valvular flow abnormalities, paravalvular leaks, and ring abscesses. Another pro is it is more sensitive in identifying pulmonary thromboembolism. Here is a picture mid-axis ascending aortic short axis view showing thrombus in right pulmonary artery. TE is more useful than TTE in diagnosing aortic lesions such as atheroma, dissection, which are often missed in TTE. So we need to visualize the dissection flap on TE, and it should be visualized in more than one imaging plane. The dissection flap should be followed along the entire length of aorta to define the extent of dissection and also identify the location of intimal tear. So this picture shows mid-esophageal aortic long axis view where we can see the dissection flap extending from the with the intimal tear at the sinus of Valsalva extending throughout the length. This shows transgastric deep thoracic aortic view, and this shows short axis view of descending thoracic aorta. Here the true lumen is the one inside and the false lumen is the one outside. TE also helps in assessing left ventricular function in hemodynamically unstable patients in ICU. We measure stroke volume using the formula LVOT area into LVOT VTI, where LVOT area is pi into LVOT diameter by 2 the whole square. We calculate the LVOT diameter in mid-esophageal aortic long axis view, and LVOT VTI is calculated in deep transgastric view, and then the stroke volume is calculated. TE also helps us in assessing left ventricular function. The first picture shows normal LV contractibility where we can see all the valves moving towards the chamber. The second picture shows end systolic obliteration of left ventricle, which is seen in hyperdynamic left ventricle or patients having decreased afterload. The third picture shows reduced LV function, where we can see hypokinesia of all the walls of the left ventricle. The fourth picture shows reduced right ventricular systolic function, leading to right ventricular dilatation, which in turn pushes the interventricular septum to the left side. So this might be due to increased pulmonary artery pressure. Thus, we can see here the IVS is displaced towards the left, as well as a dilated PA because of increased pulmonary artery pressure. T is also more sensitive in identifying the source of emboli in embolic stroke, which is most common in postoperative period. It is superior to TT in identification of cardiac source of embolism. Uh, in patients with transient ischemic attack or stroke with a normal TTE, a cardiac source of embolism was detected in TE in almost 40% of the patient, independent of the age. More than 1 of 8 patients of any age with a normal TTE revealed a major cardiac risk factor on TE, for whom anticoagulation therapy is recommended. Studies have also demonstrated that TE is superior to TTE for assessment of possible source of cardiac embolism, including intracardiac thrombi, patent foramen ovale, atrial septal aneurysm, and slow atrial flow. TE is also more sensitive in identifying intracardiac masses and tumors. Here is a picture, mid-esophageal aortic long axis view, showing a left atrial myxoma where the peduncle is connected to intraatrial septum, which is not visualized in this image plane. This tumor is moving into the left ventricle during the diastole and causing pseudo obstruction in the mitral valve. T is also more sensitive in detecting atrial septal defect, patent foramen ovale, which acts as a source of paradoxical emboli in case of embolic stroke. To diagnose this, we use echo contrast with air and a subsequent Valsalva maneuver to evaluate the presence of patent foramen ovale. All these patients were instructed to perform a Valsalva maneuver just before injection of contrast and to release on command after the arrival of contrast in the right atrium. The Valsalva maneuver was considered successful if the intraatrial septum in the fossa ovalis region shows a leftward deviation. A moderate to severe shunt, secondary to patent foramen ovale, was defined as a passage of cloud of bubbles or intense opacification of left atrium. The first picture shows an intact intraatrial septum, thus the opacification is limited to just right atrium and thus does not cross to the left atrium. The second picture shows mid-esophageal four-chamber view where there is initial opacification of right atrium and ventricle and a delayed opacification of left atrium after some 3 to 4 cardiac cycles. This denotes it is not an intracardiac shunt and it is extracardiac shunt involving either pulmonary artery and vein or hepatobiliary veins with systemic circulation. So ultimately, I want to conclude why TE is the boss. Here, this is a real-time example of a case which we did yesterday. This was a case of status post double valve replacement, came with bioprosthetic mitral valve dysfunction. The paravalvular leak on the mitral valve, prosthetic mitral valve was missed in TTE, which we found in TE. Here we can see the restricted mobility of bioprosthetic mitral valve along with the commissural paravalvular leak. This is the 3D representation of the same with the paravalvular leak seen in the 10 o'clock position. This another view showing the paravalvular leak along with the prosthetic aortic valve on the other side. So TE is usually better than TTE in certain conditions where there is poor pericardial window for transthoracic images, and also in cases involving prosthetic mitral valves and patients with postoperative patients, mechanically ventilated patients, and also useful in identifying intracardiac emboli in patients with stroke and also in diagnosing pulmonary thromboembolism and also in cases of aortic dissection. Thereby, I conclude TE is more better than TT in certain conditions. Thank you.
Thank you, Dr. Pavithra. That was very informative, and within a brief time, you have told most of the things. which highlight the importance of transesophageal echo. I'm sure Dr. Satish is going to stress on the transthoracic. So let's hear him also before going to the discussion. Dr. Satish, please.
Good evening to everyone. Transthoracic echocardiography. The indications of transthoracic echocardiography. In identifying the hypotension of unknown or suspected cardiac etiology, evaluation of ventricular function following an acute coronary syndrome, identifying the mechanisms of circulatory failure, tailoring and titrating pharmacologic and mechanical circulatory support. Focused echocardiography in patients has been increasingly utilized during the COVID-19 pandemic and found feasible for qualitative assessment of RV and LV function even in obese patients and those on IP. The objective of focus exams versus comprehensive transthoracic echocardiography is to perform a very standardized evaluation. Next, we can see the 4 views are taken. Those views we can parasternal long axis, parasternal short axis, apical 4-chamber, and subcostal 4-chamber. Both the parasternal long axis and short axis views can quantify the cardiac ejection fraction, and both can be taken in more than 90% of patients. It is necessary to use a phased array or a small footprint probe in order to look between the ribs. And thus, I am giving the images of 4 standard views of TTE. And it is the plane axis showing the TTE. Next, focus beat. Bedside echocardiographic assessment in trauma critical care. It was developed in response to the idea that pulmonary artery catheter guided transmission may be of benefit. It is utilized in the trauma setting, utilizes all 4 of the same views. It evaluates the volume status by mitral inflow and IVC diameter and collapsibility. It goes on to further evaluate for pericardial effusion, LV function, RV function, and dilatation. FATE. We all aware that it is focused assessment with transthoracic echocardiography. It is a focus exam that was created for general critical care, utilizing all the 4 standard views. It evaluates for pericardial effusion, LV function, RV function, dilatation, and lung. RUSH. Rapid ultrasound. Evaluate left and right heart size and function, effusion, IVC size, and collapse. With the short axis view, if the measure size difference between systole and diastole is less than 30%, this will indicate abnormal function. Unlike other focus exams, RUSH also evaluates the lungs, aorta, and leg veins for deep vein thrombosis, for shock and hypotension. Next, coming the advantages of TTE. It is easy to use. It is the main thing. It's non-invasive. Available in most emergency and intensive care units. It causes no harm. Information is accurate in real time. No healthcare practitioners are needed other than the performing physician. The information is obtained before the invasive monitoring. It is a cost-effective. It is safe, portable, rapid, and repeatable. And it is a study done regarding the use of handheld ultrasound device with artificial intelligence for evaluation of cardiorespiratory system in COVID-19. The conclusions are, in the rapid identification and diagnosis of cardiopulmonary manifestations in COVID-19 patients, the agreement between the handheld device and the conventional method proves its efficacy and safety. Handheld ultrasound is of more significant application in cardiac critical care. COVID-19 infection, which is associated with hyperdynamic cardiac function, stress-induced cardiomyopathy, RV enlargement, acute pulmonary hypertension, and diffuse myocardial inhibition. Good agreement between handheld ultrasound and conventional echocardiography for diagnosing pericardial effusion, regional valve motion abnormality, valvular pathologies, and left ventricular EF. Lung ultrasound has excellent sensitivity for detecting various lung pathologies such as pneumothorax, interstitial edema, consolidation, pleural effusion, and diaphragmatic dysfunction. The MRI and TTE view showing the apical aneurysm. And next is the TTE view showing the apical thrombus. The arrow indicates the apical thrombus. And a comparative study between transthoracic and transesophageal echo modalities in evaluation of left ventricular deformation. It gives the conclusion that 2D strain using TTE is user-friendly compared to TEE. Next, coming to the contraindications of TEE, perforated viscous, esophageal stricture, tumor, perforation, laceration, diverticulum, varices, Mallory Weiss tears, acute upper gastrointestinal bleeding, large descending aortic aneurysm, thoracic aortic aneurysm, Zenker diverticulum, prior esophagectomy or esophagogastrectomy, prior GI surgery, recent upper GI bleeding, Barrett's esophagus, dysphagia, restricted neck mobility, prior radiation to neck and chest, symptomatic hiatal hernia, active esophagitis or active peptic ulcer disease, coagulopathy, thrombocytopenia. Next, coming to the complications of TEE. Majority of the complications are caused by injury or trauma like dental injury, tongue necrosis, sore throat, odynophagia, dysphagia, profound gag, laryngeal palsy, hoarseness, methemoglobinia that due to the topical use of benzocaine, hypoxia, laryngospasm, bronchospasm, airway obstruction, accidental tracheal intubation, endotracheal tube malposition, congestive heart failure, arrhythmias, transient hypotension or hypertension, transient changes in heart rate, oropharyngeal, hypopharyngeal, esophageal and gastric abrasion or perforation, hemorrhage due to upper GI bleeding, hemoptysis, blood tinged sputum, cardiac tamponade, splenic rupture, hematoma and pressure necrosis. Thank you.
Thank you, Dr. Satish. You enumerated so many complications of TE. Probably I was about to ask you to stop. They are not that much what you, methemoglobinia, something are very, very rare with the amount of xylocaine used. Well, you presented nicely about the use of transthoracic echo and how it should be used and which are the conditions where it is better. Now, if there is any question from audience, I would to Dr. Murli, are the audience allowed to speak or we have to read the chat box only?
It is chat box only. The audience have joined through another link, I guess. So
But
it has to be chat box only.
So the chat box which I could open, I don't find any question in that. So
you can give your comments.
right.
And if you want
So,
to ask a question to the speakers, you please feel free.
The topic is so wide that questions are innumerable and the answer is explanatory. So just respecting the time given to this part of this today's evening session, I would say that when we compare the transthoracic versus transesophageal, we have to categorize the patients. We have to categorize the situations. For example, logistic, whether the probe is available with you or not. Many of the times the TE probe is not available. There are limited number of probes and 2-3 operations are going on. Or patients in the ICU, they require it, but the probe is not available. So at that time, it's not so that, I mean, you can't do, you should not do, you must do the transthoracic. And whenever possible, you look for the transesophageal if it is indicated. Then the type of surgery. Intraoperatively, if you are operating on the open chest or the thoracic surgery, definitely the transthoracic is out of question. And it is the transesophageal which works as a third eye to the surgeon or the anesthetist, and it's not only diagnostic, it's a monitoring tool as well. So in those situations, the transesophageal becomes much important than transthoracic because you cannot go into the surgical field. Rather, you go for the epicardial aortic echo, which is a subtype of transthoracic. I would say that you are removing the chest wall and same views you are almost the same views you are getting with the epicardial echo. Third thing is the structure of interest. If you see the structure of interest is your left side of the heart. If you are looking for the mitral wall, you're looking for the aortic wall, left atrium, appendage, the left ventricle, more or less. I think the transesophageal would be a better choice because the structure is close to it, close to the probe present in the esophagus, and there is not much of air and other things in between.
Yes.
But if you want to see the pulmonary artery, right ventricle, right atrium, right atrial appendage, or even the tricuspid wall, I would prefer, or IVC, I would prefer that Transthoracic will give you better views because it's more close. Only thing, the lungs and other things might come in between. If the patient is on ventilator, you have to reduce the PEEP or disconnect the ventilator so that the gap between the thoracic wall and the cardiac structure is reduced. So looking at the part of heart you want to see, because as we know, the heart is little posteriorly placed in the hemithorax if you take a cross section. So if looking for the heart in the posterior part of the mediastinum, I think transesophageal would give a better choice, better option to you. Even the thoracic aorta is very difficult. Descending thoracic aorta is difficult with the transthoracic. Transesophageal, it's very close and exactly entire aorta you can see. Contrary to that, if you want to see the aorta distal to the superior mesenteric or celiac artery, it is difficult. Nowadays, many people are able to see the celiac trunk, the hepatic artery, and all these things with the transesophageal echo. But beyond that, it is difficult to see with the transthoracic because it doesn't go beyond the level of stomach. Same way, there are certain blind spots in the transesophageal. Zone 2, 3, 4 of ascending aorta or distal part of ascending aorta and proximal part of arch is blinded because of the presence of right bronchus and the trachea that you cannot see with the transesophageal echo. Next is the location of the patient. If the patient is located in the ICU, very handy thing is to have transthoracic. Hardly any situation comes that you need to put a transesophageal. If the patient is collapsing and you're not finding any answer with the transthoracic, definitely you look with the transesophageal. What is the cause, especially in the post-operative hypotension or bleeding or all these things? Because posterior collection, especially in the around the left atrium or the pulmonary veins, the collection, which is very difficult to look with the transthoracic, can easily be seen with the transesophageal. Next is whether you need a continuous monitoring or intermittent monitoring. If you need a continuous monitoring, probably transthoracic would be better. Intraoperatively, for the limited time, you can have continuous monitoring of the heart functions and anatomy. But if you need it in the postoperative period, it is very difficult to keep a probe for a longer time because the probe gets heated up also. And it's very, the pressure necrosis and what are the list of complications Dr. Satish told might come over there. So postoperatively, the TE is not a choice, though there are newer inventions of esophageal Doppler and other things you can put for a longer 2-3 days also. But TE probe definitely is not indicated for a continuous ICU monitoring. Again, the diagnosis versus monitoring. For the diagnosis, probably for the structures of left side and the pulmonary artery and distal pulmonary arteries embolism, the TE gives a better result. Sometimes for the dissection, it is as good as CT or MRI. There are a lot of reports, 89% accuracy with the transesophageal echo versus 97 or 99% of the CT or MRI respectively. So it's a condition what you are looking for, whether it's a diagnosis, transesophageal, for monitoring, transthoracic, and finally comes the training. It requires a specialized training for a person to put the probe, to get the images, to understand the images, and finally to understand if you are in the OT, how do you transmit your information to the surgeon, or in the ICU, how do you transmit your information to the patient management. This is all skill that comes with experience, and a lot of training courses are done across India. So it all depends on the training part for the echocardiography. But nevertheless, the knowledge of echocardiography, the physics of echocardiography, physics of ultrasound is both common for both of them. The basic understanding of subject is common to both of them. Once you know the subject, you know the basics, you know the physics, you know what structure will look in which view normally, then only you can diagnose what is abnormal going on. So with this, I'll say that these both complement, depend on situation, location, experience, availability, all these things. Nothing is good or bad. All are good, provided they are available to us. Back to Dr. Murli.
Thank you, Dr. Rajesh, for nicely summing up the two modalities which are available to us, transesophageal and transthoracic. One other point I just would like to add is usually if patient is intubated, go for transesophageal. If the patient is not intubated, go for transthoracic. But these are general guidelines, but it depends upon the particular situation and need of the hour. And I would like to thank Dr. Rajesh for being with us and giving his valuable opinion. And I request him to stay back till the end. If there's any further question at the end, we can direct it to Dr. Rajesh and his team of Pavithra and Satish. Thank you, Dr. Rajesh. Thank you so much.
Thank you. Pleasure, always pleasure, mindset.
Thank you so much. And now I request Dr. Selva Kumar to take over and go for the second pro-con, which is Milrinone versus Dobutamine in cardiac practice.
Yeah.
Dr. Selva Kumar.
Yes, sir. Good evening, everyone. And I thank Dr. Murali sir for giving this opportunity. If you would not have given this opportunity, I don't think that we would have logged in and would have listened to all these lectures. So at least you are making us to attend and read something today. Thank you very much, sir. And now we'll move on to the first topic. I request Dr. Karishma to talk about Milrinone, the advantages and the current usage of Milrinone in our current setup. Over to Dr. Karishma, please.
Good evening, everyone. My name is Dr. Karishma Bekampadi. I will be talking about the pros of Milrinone. Milrinone is a bipyridine inodilator. It can be given intravenously as well as a nebulized aerosol, as well as orally, because it has a very good oral bioavailability of 92%. It is a selective inhibitor of phosphodiesterase 3 enzyme in cardiac and vascular muscles, which causes breakdown of cyclic AMP, thereby increasing ionized calcium and contractility. It has no beta-1 agonist activity and therefore does not increase the heart rate. Dobutamine, on the other hand, is a synthetic catecholamine and an inotrope with very weak vasodilator properties. It can only be given by IV administration. It acts directly on the catecholamine receptors, especially beta-1 receptors, to activate adenyl cyclase, which catalyzes conversion of ATP to cyclic AMP. Therefore, because it acts on the beta-1 receptors, it causes an increase in heart rate and tachyarrhythmias. Milrinone causes more decrease in systemic vascular resistance than dobutamine. Both dobutamine and milrinone increase the contractility and hence the cardiac output. However, milrinone also decreases the afterload without increasing the myocardial oxygen consumption. Milrinone decreases peripheral vascular resistance and the pulmonary capillary wedge pressures, so can be used in patients with pulmonary hypertension. Dobutamine, on the other hand, is a feeble vasodilator compared to milrinone and does not decrease the afterload as much as milrinone. It increases the myocardial oxygen consumption at the cost of increased cardiac output. It has almost minimal effect on pulmonary capillary wedge pressure. Milrinone is also known to be a potent coronary vasodilator. Dobutamine, on the other hand, is not a coronary vasodilator. Milrinone causes increase in blood flow in CABG grafts, especially saphenous and internal mammary grafts. It improves the left ventricular diastolic function and it has no effect on blood glucose levels. Dobutamine, on the other hand, has no effect on left ventricular diastolic function. It increases the blood glucose levels and the free fatty acid concentration. It can also cause CNS stimulation at higher doses. There is a downregulation of catecholamine receptors, especially beta-1 agonists, and decreased sensitivity to these receptors in patients who are on beta blockers, and patients who are on on-pump CABG, and in chronic heart failure patients. Because milrinone has no beta agonist activity, it is very much effective in such group of patients. Milrinone is most effective in short-term management of chronic heart failure, where the majority of patients have symptomatic and hemodynamic improvement. Administration of milrinone in patients undergoing off-pump CABG with low left ventricular ejection fraction is useful and effective. A study by Mehdi Haddad-Zahir from Iran conducted to evaluate the effect of milrinone on myocardial dysfunction in 80 patients with low left ventricular ejection fraction concluded that the mean postoperative left ventricular ejection fraction was significantly higher in patients receiving milrinone compared to placebo. Intravenous milrinone has also been used to reverse cerebral vasospasm after subarachnoid hemorrhage. It is also known to increase the cerebral blood flow after CPB, most likely as a result of its cerebral vasodilatation properties. Milrinone can also be safely used in pediatric cardiac surgery. Primacorp is a famous trial which was conducted. In this, prophylactic intravenous milrinone was used in pediatric patients after the surgery to evaluate the efficacy and safety of the use of milrinone in pediatric patients at high risk of developing low cardiac output syndrome. They found that the prophylactic use of high-dose milrinone reduced the risk of low cardiac output syndrome after pediatric congenital heart surgeries. And although hypotension, thrombocytopenia, and arrhythmias have been reported in adult patients, they occurred infrequently in pediatric patients and were not associated with milrinone use. Milrinone has few interactions with most drugs except maybe furosemide, and with which it causes precipitation if injected in the same intravenous line. It has a half-life of 2.3 hours and is easily titratable. In the long term, this makes it very much cost-effective. Thank you.
Very good, Karishma. You've done it very well. And you not only said that Milrinone is very good, you put all negative points about Dobutamine too. So now let's see how Praveen is going to say that Dobutamine is good. Yeah, now over to Dr. Praveen, please.
Good morning, everyone. I'm Dr. Praveen Kumar. As you can see on my slide, I'm going to present you about Dobutamine. First of all, I would like to begin with the overview of Dobutamine by giving you an overview of Dobutamine. Dobutamine acts on beta-1 receptors, which increases contractility and thus increasing heart rate and cardiac output. It also has some effects on moderate effects on beta-2, which thus helping in decreasing systemic vascular resistance and decreasing in afterload. It acts via adenylyl cyclase, thus which converts ATP to cyclic AMP, thus increasing calcium or depolarization and thus increasing contractility of the heart. The dose of the Dobutamine ranges from 5 to 15 micrograms per kg per minute. It increases cardiac contractility. It also increases SA node automaticity, leading to increase in heart rate. AV nodal conduction velocity is increased by the drug. Myocardial perfusion also increases. Decrease in both. It also helps in decrease in both left ventricular and diastolic pressure and systemic vascular resistance, and thus leading in to increase in cardiac index with severe congestive cardiac failure. It also helps in increasing in CNS stimulation at high dose. Moving on, let's discuss about its uses. It is used in myocardial infarction, where it helps by increasing coronary perfusion and thus also in improving ventricular function. It is also used in cardiac surgeries both in adult and pediatric, especially on winning of congestive, especially winning from pump, and in situation where congestive cardiac failure and pulmonary congestion happens scenarios. It also can be used in cardiomyopathy by decreasing systemic vascular resistance and in positive anaerobic activity. It also helps in patients with pulmonary edema where on positive end expiratory pressure ventilation. It is also used in septic shock it helps by increasing oxygen transport to the tissues. It is also used in cardiogenic shock by our low cardiac output syndrome, low cardiac output scenarios. It is also used in stress testing such as Dobutamine stress echocardiogram and intraoperative stress echocardiogram. There's been recent study about use of Dobutamine versus Milrinone in cardiac surgery. That was done in 2011. It is a retrospective study where the results that shown were intraoperative Dobutamine showed 4.3% death within 30 days and 11.7% death within 1 year, whereas Milrinone showed 8.5% deaths and 17.9% within 1 year. Thus, the mortality of Milrinone in cardiac surgeries is found to be high. Dobutamine is used in sepsis shock. It is typically used to increase cardiac output and oxygen transport. It also helps in increasing splanchnic perfusion and tissue oxygenation. A recent study has been performed with septic shock that showed that the Dobutamine increases oxygen transport together with improvement in intramucosal acidosis and hyperlactilemia. In addition, Dobutamine might be useful in the recruitment of microcirculation. Though dobutamine is recommended in septic shock to improve cardiac output and correct hypoperfusion, but there are controversial reports about its effect in this setting. Patients with septic shock, it has been seen that patients with septic shock commonly display varying response to dobutamine. Before a definitive therapeutic decision is taken, efficacy of and tolerance of dobutamine should be evaluated during a brief time with close monitoring of its positive and negative effects. Dobutamine in positive end expiratory pressure ventilation. Dobutamine is also used uh, in positive end expiratory pressure ventilation, especially in stage of septic shock induced ARDS. Dobutamine, the studies have shown that a beneficial effect by relieving pulmonary edema in patients without a negative elevation in preload or hemodynamics, which might account for the improvements in ventilator function and tissue hyperperfusion. It is also used in stress echocardiography, where abnormal contracting myocardial segments seen on stress echocardiography are classified either as ischemic if the reduced contraction pattern is in response to stress, or infarct if they contractility remains consistently depressed before, during, and after the exam. 16 studies have been done in 2007 as per AHA guidelines for perioperative cardiovascular evaluation for non-cardiac surgery showed that 0 to 33% of open vascular surgery patients had a positive preoperative dobutamine stress echocardiography, subsequently suffered a post of MI death. The negative predictive value was much higher, that was 93 to 100%. Wall motion abnormalities at low workloads were especially important predictors of short and long-term outcomes. Dobutamine stress echogram has indications similar to pharmacologic precision imaging with comparable sensitivity but increased specificity. For patients with such as poor acoustic windows or poor body habitus or severe lung disease, exercise stress of pharmacological stress is necessary to increase coronary blood flow for the test. Pharmacological measures are preferable, but it is contraindicated in patients with bronchospastic lung disease, in which case dobutamine may be used. It is used in patients who cannot exercise or who have a medical conditions, example cerebral aneurysm, that which contraindicates exercise. It is also preferable to exercise or dobutamine in patients with left bundle branch block because of misleading septal changes with exercise or catecholamines, which is a false positive test. Intraoperative stress exam. Low dose dobutamine, that is 2.5 microgram per kg per minute, when administered for 3 to 5 minutes, it improves coronary blood flow without significantly affecting the demand. The resultant myocardial energetics, improving existing wall motion abnormalities. Demonstration of contractile reserve using intraoperative stress echo then directs revascularization efforts to regions of myocardium able to benefit from additional blood supply. In specific scenarios where we can differentiate true severe AS with pseudo severe AS, a low left ventricular ejection fraction resulting in a low flow state, that is stroke volume index less than 35 ml per meter square and mean gradient of less than 40 mmHg, peak velocity of less than 4 meter per second, and aortic valve area of less than 1 centimeter per second square where dobutamine stress exam should be performed. If the addition of inotropic supports results in a mean gradient of more than 40 mmHg and the calculation aortic valve area remains less than 1 centimeter square, then the diagnosis of true severe AS is confirmed. If the mean gradient remains less than 40 mmHg, but the calculated aortic valve area increases to greater than 1 centimeter square, then the diagnosis of pseudo-severe AS is made. However, if dobutamine stress exam fails to increase the flow across the aortic valve and the discordant values remain, it is possible to calculate a positive aortic valve area on normal flow. For patients that fail to increase the stroke volume by 20% with dobutamine, the mortality for stroke for aortic valve replacement is high. The advantages of dobutamine input: low doses, there is generally less tachycardia than equipotent inotropic doses of isoproterenol or dobutamine. On the other hand, afterload reduction may improve left ventricular and right ventricular systolic function. It can benefit the heart with right and left ventricular failure. Renal blood flow may increase due to beta effect, but not as much as with comparable doses of dopamine or dopamine. IV or central line is preferred, but dobutamine has little vasoconstrictor activity, thus minimizing the risk of extravasation in the physician. It is also seen that compared to dobutamine at equipotent Milrinone is associated with increased mortality. Thank you very much.
Thank you, Dr. Praveen. I thought, how will you manage this tough fight with Karishma? You have done a reasonably a good job. Now I request Murli sir to say a few words about his experience in using either Milrinone or Dobutamine, whichever you are comfortable with, sir. Which drug is very comfortable, sir, for you in your center protocol?
It's a very important discussion. The Milrinone will score over Dobutamine in patients with chronic heart failure where there is down regulation of beta receptors. And also Milrinone will score over Dobutamine in patients who have been given inotropes for a long time. Beta receptor agonists have been given for a long time. Here also there will be down regulation of beta receptors, and you have to choose a pathway to improve the myocardial contractility, which is alternative or which is other than the beta receptors. So in those conditions, Milrinone scores over Dobutamine. But having said that, Dobutamine is the commonly used inotrope in most of the situations. And as Praveen pointed out, for stress testing, both with aortic stenosis and ischemic heart disease, Dobutamine is the drug of choice. And both of the drugs do not increase the pulmonary artery pressure, so both of them can be used in patients who have pulmonary hypertension. But here again, Milrinone probably is superior to Dobutamine in children with high PA pressures. Thank you so much.
Yeah, I agree with you, sir. Two drugs are very good. Both are very good drugs. But Dobutamine come very high. Always till today, in most of the 90% of the centers,
Yes.
poor ejection fraction, they take Dobutamine as the first line of management. And the Milrinone is also a very good drug and useful after 1 or 2 days or in a chronic failure or when the situation is not very comfortable with Dobutamine. And the 3 studies which have gone through, one is done in CMC Vellore by Rebecca Jacob, and she has mentioned that there is no difference in primary or secondary outcome between both groups as far as the safety is concerned, and especially the markers of CPR, heart rate, blood pressure level, there is no much difference in both groups. And one cardiac center where they do cardiac transplant, their observational studies shows that no difference in hospital mortality. But overall picture is to avoid too much of vasopressors, which can increase the left ventricular afterload. So always use some kind of inodilator along with vasopressor. This is the transplant study center as mentioned. And finally, one important study says that that is retrospective study found in that incorporated Milrinone to be associated with increased mortality when compared with Dobutamine. Finally, their study, at the end of the study, what they mentioned is after cardiopulmonary bypass or patient with failure, usage of Milrinone is increased over Dobutamine usage, as this reduces the left and right ventricular filling pressures due to reduction in vascular resistance. Or to avoid this, it is very much superior to Dobutamine. So low cardiac output syndrome following the cardiac surgery, Milrinone scores over Dobutamine in many situations. So as you know, it does not increase the heart rate also. The myocardial oxygen demand is not increased. So both drugs are very good. You have given a very tough work, sir, actually. So we are using Dobutamine, but Milrinone is also a good drug and it is useful in very many other situations. With this, I thank both the speakers. They've done the job very good, very well. And I thank each and every one of you, sir. And over to you, sir. Thank you.
Thank you, Dr. Selva Kumar, for being with us this evening and sharing your experience with Dobutamine and Milrinone. Thank you so much. And we would like to thank you. And then we go on to the next topic in the series of ProCon, that is PA catheter versus TEE. For this, may I invite Dr. S. Kumar from Madurai, again a erudite, experienced and knowledgeable cardiac anesthesiologist from South India. Dr. Kumar, please.
Yeah, thank you, sir. Very good evening to everyone. At the outset, I'd like to thank Professor Dr. Muralidhar sir and ICA for inviting for this wonderful pro-con session in cardiac surgery. After hearing about a debate on TTE versus TE and then about Milrinone versus Dobutamine, now we'll move on to the debate on pulmonary artery catheters versus transesophageal echo in cardiac surgery. You all know that there is a significant decline in the usage of pulmonary artery catheters usage in the recent decades. That may be due to various reasons, especially the complication related to the pulmonary catheters and the lack of consistency of interpretations, additional cost involved with catheters, and the lack of mortality benefit with the various studies quoted, and more importantly, the availability of alternative, less invasive methods of hemodynamic monitoring like TE. So in next few minutes, we'll have a good debate on PA catheter versus TE in cardiac surgery. For that, we have very good speakers, two excellent speakers. To talk about PAC, we have Dr. Meera, and then to talk about TE, we have Dr. Elizabeth Preethi. First, I invite Dr. Meera to talk about PAC over TE in cardiac surgery. Dr. Meera, please.
So good evening all. Today I'm going to present a topic on pulmonary artery catheter, whether it is a friend or foe. So before going into the discussion, I would like to brief about the history and evolution of the pulmonary artery catheter. So the history of pulmonary artery catheter spans almost 90 years from first reported cardiac catheterization in the year 1929. Following that, in 1970, Dr. Swan and Gans introduced balloon flotation flow-directed catheter, by which pulmonary artery catheter was developed, and it went to the next level of from diagnostic procedure into monitoring technique with continuous or intermittent measurement. And since that date, the pulmonary artery catheter has changed little in size, its structure, and has become one of the most widely used pieces of equipment, both in the operating room as well as in the intensive care unit. And there's a picture of the pulmonary artery catheter and Dr. Swan and Gans, who introduced the flotation technique. So the indication of pulmonary artery catheter, it includes both diagnostic as well as therapeutic indication. And the main important indication is it helps in differentiation among different types of shock, thereby helping us in guiding the pharmacological therapy. And it helps in differentiating between the different types of pulmonary edema and evolution of pulmonary hypertension, diagnosis of right to left intracardiac shunts, and therapeutic uses being it is used in patients with unstable angina and who are presenting with emergency surgery, both in cardiac as well as non-cardiac surgeries, in obstetric surgical patients, as well as in patients with high-risk surgery. And on the whole, it helps us in guiding pharmacological therapy. And the contraindication being infection at insertion site, tricuspid and pulmonary valvular stenosis, coagulopathy, and severe pulmonary hypertension. And this is the diagrammatic representation of the pulmonary catheter along with its port. And this is a graphical presentation of passage of pulmonary artery catheter into the chamber. And the physiological measurements which can be obtained with the help of pulmonary artery catheter is the direct measurement being CVP, right-sided intracardiac pressure, pulmonary artery pressure, pulmonary artery wedge pressure or the occlusion pressure, the cardiac output, and the mixed venous oxygen saturation. And the derived parameters are systemic vascular resistance and SVRI, pulmonary vascular resistance and PVRI, cardiac index, oxygen delivery, and oxygen uptake. So coming into the topic, whether the pulmonary artery catheter is a friend or foe, I would like to present few articles which supports pulmonary artery catheter both in the operating room as well as in the critical care setup. So the first article I'm going to discuss is, which was published in the year 2021. It was conducted in New Haven. The pulmonary artery catheter has a paramount role in current clinical practice. In this study, they summarized that the pulmonary artery catheter, when utilized appropriately, it has shown beneficial outcomes and it has not increased specific mortality in patients. And there are multiple studies which showed that certain population, especially patients who are in cardiogenic shock and heart failure, they gained benefit from pulmonary artery catheter therapy. And the next study, which was published in the year 2016, the variation in hospital use and outcome associated with pulmonary artery catheterization in heart failure in the United States. This study supported that The pulmonary artery catheter is a diagnostic tool with its utility directly linked to the interpretation of the information it provides, and it has become more prevalent, functioning as an adjunct in the use of therapy. And the summary which was given by this study is there was significant hospital level variation. Even then, there was significant decline in the mortality risk when the pulmonary artery catheter was used in treating those heart failure patients. And one more article which supported the use of pulmonary artery catheter. So this study, it gave us in which cardiac surgical patient benefit more when a pulmonary artery catheter is placed. So this study was conducted in the year 2006, and the debate of pulmonary artery catheter versus transesophageal echocardiography, it showed that the pulmonary artery catheter is superior when it comes in terms of measurement of pressures, flows, and resistance. Even though the transesophageal echocardiography provides a good profit of other parameters, the transesophageal echocardiography was more of intermittent, and it is operation dependent, and it is not a continuous monitoring method, and the trend of change will not be recorded with the help of transesophageal echocardiography. And they gave us hemodynamic data and comparison between the feasibility and reliability between pulmonary artery catheter and transesophageal echocardiography, in which various hemodynamic parameters, which consists of the mixed venous oxygen saturation, CVP, pulmonary artery pressure, left atrial pressures, cardiac output, systemic resistance, stroke volume, pulmonary resistance, all those things, they gain high feasibility and reliability when pulmonary artery catheter was used, and in transesophageal echocardiography, the reliability was low when compared to that of the PAC. So this article also concluded that pulmonary artery placement of pulmonary artery catheter was useful during intraoperative period. And next, coming to the JAMA cardiology article, which gave us the trends in use and outcomes of pulmonary artery catheter starting from the year 1999 up to 2013. So they compared the process of and the progressiveness of the pulmonary artery catheters in between those years, and they found out that there is an increase in the rate of pulmonary artery catheter use, especially in specific group of patient, that is heart failure admission, and even the clinical outcomes of patient with pulmonary artery catheters have significantly improved in those years. And the next article, which was published in 2021, the pulmonary artery catheter in cardiogenic and post-cardiotomy shock. So in this study, they concluded that the information obtained from the pulmonary artery catheter, it was central in defining cardiogenic shock. So they compared pulmonary artery catheter with other non-invasive and minimal invasive monitor. So the pulmonary artery catheter remained central in defining the cardiogenic shock. And in 2019, the expert, they confirmed that the statement on cardiogenic shock, the use of PAC for the diagnosis and management of cardiogenic shock. Next, coming to the article which was published in the year 2021, the pulmonary artery catheter in the perioperative setting, should it still be used? This is a very interesting topic because this article by itself, it compared various studies, and they came with the conclusion outcome that pulmonary artery catheter was associated with reduced hospital length of stay and reduced cardiopulmonary morbidity. And when compared with the other minimally invasive and non-invasive monitor, the mortality and the hospital stay length was less when pulmonary artery catheter was used in the patient. And all the three studies which was concluded in this article supported pulmonary artery catheter. And they also concluded that pulmonary artery catheter is never interchangeable with any other monitor. It cannot be replaced by any other monitor like transesophageal echocardiography or other minimally invasive pulse wave monitoring technique. So the summary of this study is the important variable, that is a mixed venous oxygen saturation, the oxygen utilization and delivery will not be got from the other study. So pulmonary artery catheter is always superior when it comes in terms of hemodynamic parameters. So current guidelines always recommend the use of PAC over other less invasive devices, especially in patients who have severe or refractory shock to monitor cardiac function and cardiac output continuously. And one more output from the study is that So pulmonary artery catheter use and outcomes in cardiogenic shock, it showed a reduced in-hospital mortality, as well as whenever the pulmonary artery catheter was used in patient with severe or refractory shock prior to mechanical circulatory support initiation, it always showed that patient became better with the inotropic and other vasopressor therapy with the help of pulmonary artery catheter alone without the institution of other circulatory assist devices. So on concluding with this topic, it is ideal to monitor the parameters rather than putting the patient on any mechanical circulatory support devices. And the one more study which was published in the year 2016, comparing the pulmonary artery catheter with the other arterial pulse contour analysis and transthoracic electrical bioimpedance, they gave a statement that pulmonary artery catheter is often copied and it is never equaled. So when it comes to the term of pros and cons of each of them, the pulmonary artery catheter always outweighed the pros when it was compared to other non-invasive and less invasive monitors. So in terms of, it measures the systemic as well as pulmonary circulation, and it is always a continuous measurement, and patient need not be unsedated for this procedure. And the only cons being it is invasiveness. And when considering esophageal Doppler, it is a continuous measurement, but in an awake patient, it requires sedation, and it does not measure the pressure difference, and the accuracy of this is questionable. And in transthoracic electrical bioimpedance as well, even it being a non-invasive monitoring technique, impedance affected by multiple factors also will alter the accuracy of this equipment. So it is ideal to say that the pulmonary artery catheter is often copied to, and it is never equal with any other equipment. And this is a review article which supports specifically that an pulmonary artery catheter and its usage in off-pump coronary artery bypass in terms of, so during off-pump coronary artery bypass, the positioning of the heart and verticalization of the heart may impede the quality of image which will be obtained when transesophageal echocardiography is used. So considering the impairment which is caused by sometimes placement of posterior swabs while lifting the heart or different positioning of the heart, and whenever there is presence of some air in the pericardial cavity, the image quality will be obscured when transesophageal echo is used. So it is ideal to go on and use pulmonary artery catheter in patients undergoing off-pump coronary artery bypass grafting. And the study which was conducted in 2007, they stated and they enlisted the indication for pulmonary artery catheterization. Until then, since the pulmonary artery catheter was used all over to all patients, in order to constrict the usage, so various conditions were enlisted during the study. So it consists of patients with EF of less than 40, significant regional wall motion abnormality, recent MI and unstable angina, and patient presenting with post-MI complications such as ventricular septal rupture, LV aneurysm, mitral regurgitation, and congestive heart failure, and patient undergoing a redo surgeries or emergency surgeries, etc. So this article supported in which all conditions pulmonary artery catheterization is superior. And the specific article which was done by American Society of Anesthesiology Task Force in revising the pulmonary artery catheterization use in the year 2003, it stated that not only in cardiac surgery, so when pulmonary artery catheter was used in obstetric patient and in transplant patients like patients undergoing a liver transplantation or lung transplantation, they gained some improved clinical outcomes when pulmonary artery catheter was used in terms of both cardiac, renal, neurological, and even the length of stay and mortality was reduced. And on considering all those articles which I discussed starting from 1993 up to 2022, there's still a number of glossy studies which says that there are multiple debates still going on the cons of pulmonary artery catheter, but still there is always a place for pulmonary artery catheter when it comes to cardiac or non-cardiac high-risk surgeries. So the arguments on my side for supporting pulmonary artery catheter is it is one of the superior device in differentiating and delineating the type of shock that the patient is in, thereby helping us to guide the inotropic or vasopressor therapy, thereby improving the patient outcome. And it may also facilitate the early diagnosis of shock. And other monitors have little data to support this because pulmonary artery catheter, with the use of pulmonary PAC, we can get a varied number of hemodynamic parameters, which will not be obtained by other non-invasive or less invasive monitoring. So on concluding this topic, so whether to debate between pulmonary artery catheter and TEE, it is very difficult to consider the two tools as competitors. Rather, in recent study, it has shown that Dr. Om, who's a cardiac anesthetist, he suggested that echocardiography is a potential non-invasive Swan-Ganz catheter, indicating that PAC is still the reference technique in cardiac output. It is feasible to measure this parameter using TEE, but still it is presented with certain limitation. And he also stated that the transesophageal echocardiography is strongly operator dependent, and it is less reliable when compared to that of the thermodilution technique. So, and TEE is also a semi-quantitative method, and it does not permit a continuous monitoring technique. And a study which was conducted in 2012 in Canada, it revealed that PAC remained the preferred monitoring technique among the cardiovascular anesthesiologists when a survey was taken when comparing PAC and TEE. So on conclusion, pulmonary artery catheter and TEE, they're not competitors, rather they are subsidiary tools. So high-risk patients who undergo cardiac surgeries or non-cardiac surgeries or in critical care units, they may benefit from the use of both. So this image, even though it appears to be funny, this is the ideal present situation. So on the evolving time period, we get n number of monitors, both invasive and non-invasive monitors. But still, when a right equipment is used by a right person in a right patient at right time, the outcome of that equipment will help us in patients' management and in improving their mortality and morbidity status. Thank you.
Yeah, thank you very much, Dr. Meera. It is an excellent talk pertaining to the pro and con of PA catheter versus TE. And I think you've given the verdict also. Finally, it is not a competitor, it is a subsidiary tool. It can be used as a supplementary tool. So in select situations. So I think we'll have a discussion at the end. We'll move on to the next talk by Dr. Elizabeth Preethi on TE in cardiac surgery. Dr. Elizabeth, please.
Good evening, everyone. My topic today is comparison of transesophageal echocardiography versus pulmonary artery catheter. Transesophageal echocardiogram, or TE, is one of the ways to perform an echocardiogram. A specialized probe containing an ultrasound transducer at its tip is passed into the patient's esophagus. This allows imaging of the heart and Doppler evaluation, which can be recorded. Intraoperative transesophageal echocardiography is a standard diagnostic and monitoring tool employed in the management of patients undergoing an entire spectrum of cardiac surgical procedures, ranging from coronary artery revascularization to complex valve repairs and various other procedures. According to ASA and SCA practice guidelines, TE should be used in all adults for all open heart surgery and thoracic aortic surgical procedures unless contraindicated. TE should be considered in coronary artery bypass grafting surgeries. TE is necessary in the intraoperative management of cardiac patients for the following reasons: to confirm and refine the preoperative diagnosis, to detect new and unsuspected pathology, to adjust the anesthetic and surgical plan, and to assess the results of surgical intervention. TE is rapidly becoming a modality of choice to determine the volume status of patients. In the era of cost containment, use of intraoperative TE may prove to be a very simple, non-invasive, and reliable alternative to PA catheter for estimation of LV preload. TE is non-invasive. It uses ultrasound waves to visualize the heart and its structures from within the esophagus. In contrast, a PA catheter involves the insertion of a catheter into the pulmonary artery, which is an invasive procedure and carries risks such as infection, bleeding, and vessel damage. TE can be inserted quickly, and it is safer as it does not enter any great vessels or the heart. TE provides real-time imaging of the heart, allowing direct visualization of cardiac chambers, valves, and other structures. This enables the detection of abnormalities such as ventricular dysfunction, valvular dysfunction, intracardiac shunts, masses, etc. It provides a detailed assessment of valve function. A comprehensive evaluation of valve function, including assessment of valve structure, leaflet mobility, and severity of regurgitation or stenosis. This information is valuable in guiding treatment decisions, such as the need for surgical intervention. TE can be used during certain procedures such as transcatheter valve interventions or intraoperative monitoring during cardiac surgery. Its real-time imaging capabilities allow for precise guidance and assessment of the procedure. TE can also be used for assessing hemodynamics. It allows quick identification of abnormalities such as hypovolemia or cardiogenic shock. One of the commonest indications for use of TE is assessment of ventricular function. TE provides rapid assessment of the LV function by providing high-quality images in multiple planes and positions. Transgastric short-axis view of the LV is easily obtained by TE and provides assessment of ventricular walls supplied by all the coronary arteries. It can be used for ischemia monitoring. TE is highly sensitive for detection of ischemia and detects occurrence of myocardial damage even before the markers for cellular damage can be detected. However, there are many other non-ischemic causes for wall motion abnormalities, such as sudden changes in loading conditions and conduction abnormalities. Emergency TE. Assessment of hemodynamic instability is one of the most important indications for TE. Especially in cases of trauma, a rapid diagnosis is essential prior to institution of therapy. In critically ill patients in the ICU, use of TE helps in reaching a quick diagnosis and improving management and outcome. Over several decades, PA catheter has fallen out of favor in the management of deteriorating patients due to its risks, variability in proficiency of placement, and multiple prospective studies showing no benefit in their use. Moreover, many surrogates of hemodynamic measurements obtained by PA catheter, including cardiac output and left ventricular volume status, can also be measured using echocardiography. For example, there is clinically acceptable correlation between systolic pulmonary artery pressure when measured by PA catheter or when calculated from echocardiography in ventilated patients. According to a study conducted by McKay et al., they assessed over 8 lakh patients undergoing cardiac valve or aortic surgery between 2011 and 2019, and they found that intraoperative TE use was associated with a lower 30-day mortality, a lower incidence of stroke, and a lower incidence of cardiac reoperation. These are my references. I would like to conclude that I would like to use TE for all my patients unless it is contraindicated. Thank you.
Thank you, Dr. Elizabeth, for eliciting about the role in cardiac surgery. So to summarize, we had a very good talk by both the speakers. First by Dr. Meera about PA catheters. She was talking about long history of PA catheters, more than 50 years, indication, contraindications, all those things. The pros about PA catheters in cardiac surgery, as per her talk, is it is having a beneficiary outcome in goal-directed therapy, and it decreases the mortality risk in heart failure patients, and it is superior in measurement of pressures, flow, and resistance. There is no doubt about it. And there is a continuous monitoring compared to TE. There is a continuous monitoring by PA catheters. And number 5 is it helps in diagnosing and management of cardiogenic shock. And it also, by a few of the studies she quoted, it reduces the length of stay and reduces the mortality. Though it is a controversial one, there are many studies which are against use of PA catheters about in terms of length of stay and mortality. There is no reduction in the incidence of mortality and length of stay. And the accuracy. The accuracy is better compared to other methods, like other alternate less invasive methods. And in OpCap, during positioning, PA catheter is superior to TE. And there is an article she quoted that in OpCap about the indications, like in patients with less than 40 EF and also in mechanical complications. Definitely there is a role for PA catheters in those type of select patients who are undergoing OpCap. So this is about her point of pros, and it is well elucidated by Dr. Meera. I congratulate her for an excellent talk. And she also came out with the verdict that PA and PA catheter and transvascular echo are subsidiary tools. It is not a competitors. they can mutually benefit each other or complement each other in terms of monitoring tools during cardiac surgery. Coming to Dr. Elizabeth Preethi's talk about TE, she has elucidated about TE's usage in cardiac surgery, about assessment of valvular function, ventricular function, ischemia detection, all those things. In terms of hemodynamic assessment, she clearly mentioned about that it is a reliable tool for assessing the volume status. It is better than PA catheters in assessing the volume status. So that is her version. The article also supporting that T is superior to PA catheter for assessing the LV preload in terms of LV and area and diastolic area. we can measure that preload more precisely compared to PA catheters. So many articles supporting that. So by comparing, by analyzing both the talks, it is very clear that there is a definite role for PA catheters in the perioperative setting till now. So PAC remains a gold standard for continuous hemodynamic monitoring, especially in cardiac output measurements in select population like high-risk patients and those undergoing high-risk procedures with high hemodynamic instability, and patients with the transplants, and in chronic heart failure patients, and in patients who are not able to differentiate the shocks. Those situations, definitely there is still a role for PA catheters. Of course, the routine use of PA catheter is in cardiac surgery is not in practice for more than a decade, as per the guidelines and evidence. That is known to everyone, and that is very clear. With the evidence, there is no role for routine use of PA catheters in cardiac surgery. TE usage is increasing, being a less invasive and more reproducible one, but it needs expertise, experience, and availability of logistics and probes, all those things. TE cannot replace PA cath in select population. It can complement each other. So PA catheter still has its role in select population, and TE can complement in these particular type of patients. That is my inference from this talk and my opinion about this debate. Everything is open for discussion. Is there any questions, sir? Nothing, sir.
There is one comment from
Yes,
Ratan
yes.
saying that
Yes, sir.
For pericardial effusion and hypertrophic cardiomyopathy, TE is better.
No, sir. I
That's
accept
what-
that. Totally accept that it is it definitely helps in diagnosis of tamponade and hookam, but we cannot compare PA catheter versus TE in those situations. In PA catheter and TE in hemodynamic monitoring only, then the debate should be there, because TE usage and role is very vast, and it is definitely useful. I think Dr. Rajesh wanted to add something. Rajesh, please.
Yeah, two things I just want to say about it. The PA catheter gives you a cardiac output of the right side of the heart. And if you go to the advanced PA catheter, like continuous cardiac output and all, there's a time gap of 3 minutes between the calculation and it is reproduced on the screen. So it may not be that good versus the TEE or echocardiographic, where we see the left side of cardiac output, which is actually the tissue perfusion we are concerned with.
Thank you.
Second thing, the PA catheter just gives the physiology or the hemodynamics only, but the TE, other than hemodynamics, it gives the anatomical information as well. So where it values more than the PAC catheter probably. These are the two. Definitely for the continuous monitoring, we need the PAC catheter, and that to the trends of the PAC catheter, not individual value. And same way, the T you cannot keep for a long time. That's a ICU becomes difficult. That's all. Rest all is all fine given by all the candidates, all the two people.
Yeah,
Thank you.
Agree with
Thank
what,
you.
Agree, sir, just one point. Agree with what Rajesh said and Kumar said. PAC has a big advantage of giving you a trend over a period of time, whereas TE, the experts may change over a period of time. the trending, the information may be lost and you may have to put in the probe again and again. So it's an intermittent basis, whereas on PSC you get the continuous trending. So that's an advantage of PSC.
Thank you for that. I would like to thank Dr. Kumar, Dr. Rajesh and Poonam for their comments, and the two youngsters, Meera and Elizabeth, who have presented the topic. Thank you so much. Before I hand over to Dr. Kanagarajan, I just want to make a comment that if you want to know the mixed venous oxygen saturation, pulmonary vascular resistance, or systemic vascular resistance, PA catheter is much easier and useful. And the other comment I want to make is that the downfall of PA catheter was based on studies in critical care units. Please note this, the downfall of PA catheters was based on studies in critical care units where the physician there used the PA catheter as a last resort. When the patient was collapsed, when the physiological deterioration occurred, then the intensivist or the physician there used it and then concluded that PA catheter does not help in salvaging these patients. So when we read this article, we should take that fact into consideration. With that comment, I would like to proceed on to the next presentation. This is a debate on off-pump and on-pump. And I would request Dr. Kanagaraja Natarajan to take over and conduct this debate. And Kanagaraja Natarajan is very well known to all the cardiac anesthesia fraternity in India and abroad, and he is very experienced and his input will be very valuable. And I hand over to Dr. Natarajan. Thank you so much.
Good evening, sir. Good evening, everybody. It is really it's my pleasure to do that. Before coming to the final verdict on me on the on pump and off pump, because this is one of the very big gray area in cardiac surgery. So we can have a long discussion about which is good, which is not good. So more than the pro and con, what I can say that there are certain indications for on pump, and there is a role for off pump. So till now, as far as my knowledge, it has not been proven that which is superior, which is inferior. So let us listen to the speakers. Then we can come to a conclusion about what the current evidence says about the whether it is on pump is superior than the off pump, or off pump is still having a role in the current management of coronary artery bypass grafting. So let us move on to Dr. Nishant. Yeah, please.
Good evening, respected judges, moderators, and delegates. My topic today is pros for on-pump CABG. Although initial observational studies with off-pump CABG suggested similar or better outcomes compared to the conventional on-pump CABG, conclusions were likely flawed due to multiple source biases, and other randomized trials have been too small to demonstrate conclusive clinical superiority of one technique over the other. In 2012, a meta-analysis and systemic review of 86 randomized trials compared these two surgical techniques. They found that off-pump CABG significantly increased the all-cause mortality in all the trials. I would like to highlight the following trials today. The Ruby trial randomly assigned over 2,200 relatively low-risk patients scheduled for elective or urgent CABG to either off-pump or on-pump procedures. The rate of primary outcome, that is, composite death from any cause, repeat revascularization procedure, or a non-fatal myocardial infarction within 1 year after surgery, was significantly higher in off-pump, including significant increase in the rate of death from cardiac causes. The proportion of patients with fewer grafts completed than originally planned was significantly higher in the off-pump group. At 5 years, the rate of death was higher in the off-pump CABG group. Approximately 43% of the deaths were cardiac related, and the rate of other 5-year endpoint, that is a composite death from any cause, repeat revascularization, and non-fatal myocardial infarction, was also higher in the off-pump group. An angiographic evaluation follow-up study was done in over 1,300 cases enrolled in the Ruby trial, and they were evaluated for graft patency. At 1 year, graft patency was significantly worse in those who received off-pump CABG. A 1 year adverse clinical event rate, that is death, non-fatal myocardial infarction, or repeat revascularization, was significantly high in the off-pump CABG group. The coronary trial in 2012 randomly assigned over 4,700 patients scheduled to undergo isolated CABG surgeries, either off-pump or on-pump. The patient represented a higher risk group compared to those enrolled in the Ruby trial, and the surgeons in this group had a higher level of expertise compared to the surgeons included in the previous trial. At 1 month and at 1 year, there was a trend towards higher rate of revascularization in patients who received the on-pump treatment. This study, over 20,000 patients were included, and off-pump surgery was performed by surgeons who routinely perform off-pump surgeries, and on-pump surgery was typically performed by surgeons who perform on-pump surgery as a routine. Hence, in this study, we have a surgeon matching while comparing the two groups. The patient who tend to be on pump usually had a higher degree of renal dysfunction, ejection fraction of less than 35%, diabetes mellitus, left main pathology, previous history of stroke, and peripheral vascular disease. Hence, I may say that you find the sicker patients in this study expected to have worst outcome, and they are put in the on-pump group. Let us see what the results are. If we look at the blue line, which is the outcome of the patients who underwent off-pump CABG, comparing it with the orange line, which represents patients who received on-pump treatment, there is a significant increase in the mortality amongst the patients who received off-pump treatment. Myocardial infarction, stroke rates, and rate of new onset renal failure requiring renal replacement therapy is essentially the same, as we can see in the picture. But the difference is evident that off-pump had a higher failure rate, that is represented by the third graph, in which repeat revascularization is significantly high in the off-pump group, which essentially means that early graft failure was higher in patients who received off-pump treatment. This is evident because we are trying to operate on the heart at odd angles, and because we have to maintain a hemodynamics by maintaining the perfusion pressures and flows, and there is no pump to support the patients, we are trying to create the same quality of anastomosis, and that is possible only on a resting heart. This trial shows the outcome with respect to the site of graft placement, and we can clearly see from the graph that there is increased graft patency in patients who underwent CABG on pump compared to CABG off pump. In addition, off pump CABGs have a lot of disadvantages as it requires a skilled operator. It is technically more difficult. The proposed neuropsychological benefits are not clearly demonstrated in any trial. The more difficult and diffuse diseases with smaller arteries are usually avoided on off pump. There is increased chance of risk of bleeding and infection, irregular heart rhythms, and blood clots leading to strokes and myocardial infarctions. In aggregate, the study that have compared off-pump technique to the on-pump technique for patients undergoing CABG has found an increased rate of repeat vascularization, increase in incomplete vascularization, increase in the long-term mortality with off-pump techniques. But still, my beloved colleague out there will insist on an off-pump procedures for all the cases, and I really don't know why. Hence, I would like to conclude that on-pump technique is a better choice in most of the patients compared to off-pump technique for CABG? Thank you.
Yeah, this is the routine, what do you call the argument put forward for the on pump. One is the number of grafts, then the seeker patients, then the posterior grafts. So let us listen to the other speaker, what they have to say about their point. So let's listen to Dr. Madhu about the on pump, off pump. Then let us have a common discussion on whether really any advantage is there, one technique over the other technique. Dr. Madhu, please go ahead.
To respected faculty and all my dear friends. One of the most hotly debated and polarizing issue in cardiac surgery has been whether a coronary artery bypass grafting without use of cardiopulmonary bypass is superior to that performed with an extracorporeal circulation and heart being chemically arrested. Coronary artery bypass graft surgery has recognized as one of the most principal therapies to prolong survival and improve the quality of life of patients suffering from coronary artery disease. In off-pump CABG, the area around the blocked coronary artery is stabilized using a myocardial stabilizer as shown in the picture while the surgeon grafts the blood vessel on pumping heart. The advantages of off-pump CABG is no aortic cannulation, so less risk of aortic dissection or embolism. No atrial cannulation, so less atrial injury or arrhythmias. No cross clamping, so less risk of plaque embolism, cerebrovascular accidents, myocardial infarction. No activation of coagulation, calciferins, inflammations caused by the tubings. No cardioplegia, so no potassium overload, fluid overload, or coronary air embolism. No risk of bypass machine failure, so less risk of air embolism. Preferred option in older patients more than 75 years. Less cost, less equipment, less staff. I would like to support my statement with evidences and recent published studies. In interest of time, let's have a look at them one by one. This is an article published in Texas Heart Institute Journal in 2007. Systemic and myocardial inflammation in traditional and off-pump cardiac surgery. In this, a tumor necrosis factor alpha in on-pump versus off-pump study has been discussed, where they have found that on-pump have more risk of systemic inflammatory response. So here they conclude that off-pump CABG appears to reduce systemic inflammation without reducing myocardial oxidative stress and inflammation. This is our own study published in Narayana Health Institute. He published in Annals of Cardiac Anesthesia in year 2000. They studied the biochemical markers of myocardial injury during coronary artery bypass grafting with and without cardiopulmonary bypass. So they concluded that serum concentration of cardiospecific enzymes CPKMB and troponin T were estimated in all the patients from pre-induction period to 72 hours after bypass graft. So they have found that those in off-pump CABG, these levels are a bit less. This is another article to support my evidence that off-pump versus on-pump coronary artery bypass grafting, the perioperative complications and early clinical outcomes. Mechanical ventilation is for more than 24 hours has been seen higher incidence in on-pump CABGs as compared to off-pump CABGs. So here they conclude that there is a rebirth of off-pump CABG during the last decades, and advantages associated with use of this technique is repeatedly emphasized. Due to the innovative technical development, off-pump CABG can now be safely offered to patients with multivessel coronary artery disease. It must be emphasized, however, that despite early report of good results, long-term studies are needed to encourage the use of this technique. This is another article published by Lima et al., which says that on-pump versus off-pump coronary artery bypass grafting in high-risk patients, operative results of prospective randomized trial. They have found that in high-risk patients with Euro score of 6 or more, off-pump CABG reduces early mortality and morbidity, that is myocardial infarction, neurological complications, renal failure, reoperation from bleeding, ARDS as compared to on-pump CABGs. This is another article published in Interventional Cardiology Journal in 2014, which says that risk of stroke after coronary artery bypass grafting, specifically in propensity matched analysis involving more than 42,000 patients, there was 35% reduction in risk of stroke in patients treated with off-pump CABG as compared to those with on-pump CABGs. This is yet another article published in Narayana Health Institute by our own Dr. Muralidhar Kanchi sir, which studied off-pump CABG techniques may prevent worsening of renal function in CAD patients with CKD undergoing CABG. So here you can see in POD1 and POD5, in both these cases, the renal parameters are a bit comparable. The p-value is less than 0.01. There is another article which says kidney function after off-pump or on-pump coronary artery bypass grafting. Here they conclude use of off-pump compared to on-pump surgery reduces the risk of post-operative acute kidney injuries. This is another article which studies transfusion and bleeding in coronary artery bypass grafting and on-pump versus off-pump comparison. This is an article published in Journal of American Society of Extracorporeal Technology in 2007. They have studied the rate of blood transfusion in on-pump and off-pump CABGs. As you can clearly see in off-pump CABGs, it is only 23.8%. So here, with all these evidences, I conclude that myocardial revascularization without CPB is a valid alternative in high-risk surgical patients like patients with CKD, previous history of stroke, old age, or with coagulopathies, as it reduces overall morbidity, the need for transfusion, and length of hospital stay. Thank you.
Thank you, both the speakers. You have both of you put forward your points for that. But let us take one by one. Now, let us discuss about like why we always say that on-pump is disadvantages, whether it is really proven. So now take the number of grafts, for example. It has been clearly shown with all the studies that number of grafts are always higher with the on-pump than the off-pump. There is no question about that. That means, are we underplaying the myocardial revascularization just because we want to do on-pump, off-pump? The 1%. Second thing is, if you look at any data, the data with the graft patency proven by angiogram, there is very, very less data from the Indian perspective, where number of off-pump surgeries are very, very high. But if you take the abroad data, even including the latest meta-analysis and the reviews, the graft patency has been proven superior in on-pump with repeat angiogram. So what we need from Indian data is, one thing I accept that when you look at most of the studies from the abroad, they say that experienced, so-called experienced op-cap surgeon, like when they do more than 20 cases per month. So if we do have the on-pump data, off-pump data from India, the experience of our surgeons may prove, even in terms of graft patency, better with or non-inferior or what you call equal with on-pump. But the problem is we lack Indian data with repeat angiogram. We have a clinical data, I accept. We have a clinical data from India showing that on-pump is having a better renal function. Yes, it's a very well accepted because one of the major reason for renal dysfunction after a CABG is your pump. So when you're removing the cardiopulmonary bypass, we expected to have a lesser incidence of renal dysfunction, I accept. But what about the main, what you call the aim of your revascularization? The graft patency, where is the proof? Till now, we don't have a concrete data about the graft patency with superiority of off-pump. That's the only drawback with the off-pump data. Now, third, stroke. Do we have really evidence to say that the stroke is less in off-pump? I don't think so. Then atrial fibrillation. Do we have a really good data with showing that atrial fibrillation is less with the off pump? No, because if you come to the stroke, your aortic manipulation is the main culprit in stroke rather than your pump. So still there are a lot of questions to be answered to say that off pump is superior or equally or better than on pump. I accept that still there are certain subset of patients definitely going to benefit with off pump. For example, as severe pulmonary restrictive disease, definitely off pump is going to be better. And CKD on dialysis, yes, I accept that it is going to be benefit the off pump. But what about the hypotension you are going to create in a patient who is susceptible for renal dysfunction? I accept that CKD with the dialysis dependent, I accept that off pump is going to be better. But what about the patients who is having a high risk for renal dysfunction, where you are going to create a hypotension during your grafting? Is it going to be beneficial? Is there any data to show that? So still we are having a lack of evidence to show that off pump is better than on pump or off pump is equal to on pump. But there are still role in off pump for certain specific subset of patients where you will have a better outcome. So till the debate is going on and till we don't have a lot of data with the repeat angiogram to show that the graft patency is equal to on pump. That is the fact which we have to understand, because we are looking at the Indian data which shown the clinical benefits. But we are lacking the data which had shown, which is showing a graft patency and number of grafts. So at this point, there is a role for off pump, but I can say that from the current evidence, still we have not able to prove that off pump is better than on pump. Thank you. Now I leave it to the seniors here who are having much more experience than me in off pump cases. So I request Dr. Muralidhar sir to have some comment on that. Yeah.
Thank you, Kanagarajan. You have put the nail in this correct place. I think what you said about we lack the angiographic data to show that the grafts performed by Indian surgeons are as good as on pump or better than on pump. That's a very valid statement. And I concur with what all you said. And unless we have angiographic data, we cannot say that off pump is as good as on pump. And also, what else I wanted to say? That's all I think. And thank you so much for joining us. And I'll thank both the speakers for their excellent presentation, Madhu and Nishant. And thank you,
yeah,
Dr.
Thank you.
Thank you so much. Thank you so much. Thank you so much. And we move on to the next section of the ProCon, that is IABP versus Impella. We have Sushrita and Syed speaking about it. And I request Dr. Poonam M, who is very well known all over the Indian world about as a eminent personality in the field of cardiac anesthesia. And she has authored several books, and she has her own society called the Simulation Society and her own journal called Journal of Cardiac Critical Care. It's a great pleasure for me to introduce her to you. Actually, she does not need any introduction. And Dr. Poonam M, please.
Thank you, Dr. Muralidhar, for this very golden opportunity to connect with the students, because I think this is a very good thing. We need the younger people more involved, and this is the best way to do it. When they speak and someone else gives their comments, and no better than you being a leader in all this. Thank you for the opportunity again. And thanks for giving me a very good topic, IABP versus Impella, and two young students to tell us about it, because both the use of IABP, which started at 1952, with Kantrowitz introducing it first in the animal studies, and finally in 1970 we adopted the IABP for use all over the world in humans. And Impella versus that is a very new entity, only introduced in 2017. And the very hotly debated LVAD, since it's the smallest heart pump available, I think the FDA USA has been flooded with only two topics. One is the recall of the oxygenators, and the other is the use of Impella and where to use it in heart failure patients with Intermax registry level 1, or to use it in cardiogenic shock or high-risk PCI, and both can be used. But which is better? I'm sure these two students will tell us. IABP, to my mind, has little or minimal effects on systemic circulation. Since it has very minimal effects, it is locally with the help of a small balloon inflating and deflating the heart and causing extracorporeal counterpulsation, which is in a way giving a forward flow. And during diastole, when the coronary refilling is happening, it is causing an increase in the cardiac output. But this increase in the cardiac output is very minimal. On the other hand, with the 3 or 4 types of Impella which is available, and with science and evolution will come better gadgetries. The Biomed company has introduced a LVAD which can be put percutaneously, the Impella CP as well as Impella RP, and not the Impella 5 or 5.5, and it can deliver up to 2.5 to 4 liters of blood, augmenting the blood from the LV directly into the aorta, therefore unloading the LV. So profound systemic circulation effects with the Impella, but both are not without disadvantages. And let's listen to Dr. Sushrita Sahoo and Dr. Sabir Syed Ali on IABP and Impella. So over to Dr. Sushrita Sahoo for IABP first.
Good afternoon, everyone. So here, Dr. Sushrita Sahoo. I'll be speaking in favor of use of IBP in cardiogenic shock. So coming to what is shock, Society of Cardiovascular Angiography and Intervention Clinical Expert Consensus Statement, they have classified cardiogenic shock accordingly: at risk, beginning, classical, deteriorating, and extremis. So depending on what type of mechanism of shock patient is in, and anticipated benefits and risk of mechanical circulatory device, and ideal timing for device insertion, vascular access requirement, and hemodynamic support provided, will choose what kind of mechanical support devices will use. So that includes IVP, Impella, tandem heart, VA, ECMO, IVP being pulsatile flow pumps, but Impella comes in continuous flow pumps category, but IBP and Impella both are intracorporeal circuit. What is IBP? It consists of a flexible 30 to 50 cc helium-filled balloon catheter attached to a console. So that balloon augments pulsatile blood flow by inflating during diastole and thereby increasing diastolic pressure in the aortic root and enhancing coronary perfusion. During systole, rapid deflation of the intra-aortic balloon generates a pressure sink, which reduces LV afterload and increases LV cardiac output. So here, LV, left ventricle pressure volume loops, that shows acute decrease in left ventricular end systolic volume by 6% and a decrease in left ventricular end systolic pressure by 18%. So overall increase in stroke volume by 14%. Hemodynamically, we can see a decrease in systolic blood pressure, increase in diastolic blood pressure, and an increase in mean arterial pressure. So what are the advantages of IBP over Impella? It is relatively cheaper and largely available in all the tertiary centers. Insertion is more straightforward and can be performed in ICU without the need for fluoroscopy. Associated with adverse events, few like vascular complication, bleeding, and hemolysis, limb ischemia, and placement in axillary or subclavian artery that will facilitate early mobilization and early physical rehabilitation of the patient. In case IBP fails or cannot be weaned off, rapid escalation is possible to percutaneous mechanical circulatory devices, VA ECMO, or more durable mechanical circulatory devices. And IABP can easily be removed, and presence of IABP does not complicate native heart excision in case of bridging to orthotopic heart transplant. So in this article by Muralidhar Kanchi et al., in cardiac, they took a cardiac surgical cohort of 4,500 adult patients where the incidence of IVP use was 4.5%. They showed a mortality rate overall was 28%. Then coming to CRISP AMI trial that showed no reduction in infarct size or mortality by strategy of percutaneous coronary intervention with prophylactic IVP support. But in the study by Van Noonen and Van Tier et al., placement of IABP in selected group resulted in more frequent ST elevation resolution compared with control group. Then coming to balloon pump assisted coronary intervention study. This study showed all-cause mortality at a median follow-up of 51 months was significantly lower in the planned IABP group versus the percutaneous coronary intervention alone. Then coming to this study by Malik and Fried et al., patients with non-acute coronary syndrome cardiogenic shock experienced a 5-fold greater cardiac output augmentation compared with patients with acute myocardial infarction cardiogenic shock. And in this study, IABP Shock 2 trial, it included patients with cardiogenic shock complicating acute myocardial infarction, 300 in IABP group and 298 in control group. There were no significant differences in 30 days mortality, which was the primary endpoints, and secondary endpoints includes time to hemodynamic stabilization and length of stay in ICU. So for this, European Society of Cardiology has downgraded the use of IABP in STEMI from 1C to 2B recommendation. And this may be accountable because of the limitations to the study, like small size and crossover designs, which could not rule out type 2 error. Coming to this study by Dhruva et al. That showed significantly high risk of in-hospital death associated with intravascular microaxial LVAD. And according to Shrej and Ibrahim's et al. Study, use of Impella was associated with no difference in 30-day all-cause mortality compared with matched patients from IABP Shock 2 trial. And severe or life-threatening bleeding was higher in Impella group. And last slide, the usefulness of intra-aortic balloon pump in patients with cardiogenic shock. It was when it was placed within 1 hour of onset of cardiogenic shock, it was having 30-day mortality of 24%, while 49% when implanted more than 1 hour after recognition of cardiogenic shock. Thank you.
Thanks a lot, Dr. Sushrita. You nicely showed that in the Shock 2 trial, the European guidelines made the IABP come down from a level of evidence of 1C to 2B. In fact, if you read the most recent guidelines of 2023, according to the Japanese study of GIST and also the European study of GIST and the Japanese study by Ikeda et al., the level of evidence given today is class 3. So why IABP has come down? Obviously, for a few reasons, that the mortality benefits that we had envisaged are not so much great. But at the same time, let's listen to your counterpart for Impella, because there is no new or old invention which can be done away. The newer inventions are also not without fault. So let's see the advantages and the disadvantages of Impella by Dr. Syed Sabir Ali. Over to Dr. Syed, please, for talking and his take on Impella.
Hello, everyone. I am Dr. Syed Sabir Ali. I am going to present about Impella for cardiogenic shock. Impella is a mechanical circulatory support system with continuous flow via axial plumb and which expels blood from left ventricle to aorta. It can produce cardiac output of 2.5 liter to 5 liter. It can be used from 10 days to 3 weeks. And the advantage of Impella is it is ECG and pulse independent, and it can be easily inserted in the cath lab in emergencies condition. and there is no extracorporeal blood flow. So the current guidelines recommend the use of Impella as a bridge either to recovery or reevaluation, transplantation, or a permanent implanted LVAD. It can provide up to or more than 5 liters per minute of cardiac output, depending on the size of device used. So, the recent guidelines of European Society, they have raised the recommendation level for short-term mechanical circulatory device system like Impella from class 2B to class 2A. According to Recovery 1 study, they saw the patients with post-cardiotomy cardiogenic shock. The Impella 5.0 was associated with 94% and 81% and 71% survival at 30 days, 6 months, and 1 year, respectively. And in another study of O'Neill et al., they show that usage of IABP patients with anterior ST segment myocardial infarction and cardiogenic shock is not associated with clinical benefit, and it is no longer recommended. Therefore, research is currently directed at potentially more powerful devices for percutaneously mechanical circulation. In a study of recovery right study, they saw that patients with life-threatening right ventricular failure, the novel percutaneous Impella RP device can be safely used and deployed. Impella can be used in many other non-AMI cardiogenic shock cases like post-cardiotomy cardiogenic shock, in fulminant myocarditis, in severe AS, MR, severe AR, MR, and in like Takotsubo syndrome and peripartum cardiomyopathy. And Impella can be used as unloading strategy during VA ECMO, where they have found that LV unloading with Impella remained associated with significant reduction in mortality. In another studies of high-risk PCI, they have showed that Impella support is associated with 55% improvement in survival and 71% reduction in MI and 46% reduction in cardiogenic shock with no observed difference in rate of stroke and bleeding, recurring transfusion or AKI. And they have also shown that they didn't identify any increased risk of stroke or bleeding, recurring transfusion with Impella compared with IABP. In the study of Protect 2 study, they saw that reduction in deaths of stroke and MI or a composite of death, stroke, and MI at 90 days with Impella 2.5 compared with IABP among patients who received the intended mechanical circulatory devices. Thank you.
Thank you, Dr. Ali. I think you nicely spoke about the Impella, its advantages and disadvantages, and quoted the right studies suggesting where all Impella can be used despite not only cardiogenic shock. But something that the new Impella guidelines say, you mentioned that Impella could be used in severe AS, in AR, in MR. You said it could be used in Sahoo. Could you quote the Santero study, the G study from Germany, Italy, and Spain, which has just been released in circulation in May 2023 itself? What does it say on the use of IABP and Impella in Takotsubo? Could you narrate, and have you heard of that study? Okay, now that study is a very good study, which is bringing forth many scientific facts together. The first and foremost being that when we use an IABP, what is an IABP doing? An IABP reduces the afterload in systole, right? Now, when it is reducing the afterload in systole, it is increasing the coronary blood flow in diastole. But at the same time, in a case like Takotsubo, it is causing an LVOT obstruction. Why? Because it is increasing the transaortic gradients. So it is important when you put an IABP in a Takotsubo, the mortality benefits are not there. The success rate of IABP in Takotsubo is very, very little. It's the minimal because it is causing an LVOT obstruction due to these high transaortic gradients, which the Impella does not. Impella 2.5 can deliver only up to 2.5 liters, and the Impella 3.5 up to 4 liters or 3.7 liters of the coronary flow or the cardiac output. Whereas it is with the coming of Impella 5.5, what is Impella doing? It is unloading from the LV into the aorta. So it's forwarding the antegrade flow. And when it forwards the antegrade flow, which is the physiological flow, it scores over what the IABP or the ECMO were doing. ECMO provides, the VA ECMO, when we use in Takotsubo, is providing a temporary relief, and it's a retrograde flow, right? So that's why the using of Impella with VA ECMO, the Ecpella, is a very, very good condition today. And the recent Japanese study has come up again in February 2023 to say that it is with the use of Ecpella or the use of 5.5 Impella that you are going to have more cardiac output delivered. And if used within 14 days and not exceeding 60 days, the Japanese study says this, the chances of mortality benefits, which were equal so far till 2022 December between IABP and Impella, Impella will score. But what is the downside of using a VA ECMO and an Impella? Hemolysis, hemorrhage, bleeding, hematomas, and stroke. These remain disadvantages of the use of Impella, which may not be seen so much with the use of IABP. So whereas you have hemolysis, you have hemorrhages with Impella and not have them with IABP, you must know judiciously where to use IABP and where to use an Impella. But since my time is running out, I would just like to sum it up and thank both the speakers because they brought out the best and gave very pertinent recent literature quoting their cause for IABP and for Impella. I would not do without IABP. It is the cheapest and the most easily used modality since the last 70 years. Anything that is been of survival benefit in a low cardiac output state should be used. So if there is a hypoperfusion, a pre-shock stage, and you're putting it in a time window of 89 minutes, in an early cardiogenic shock, IABP scores. The time limit or the window in which you put an IABP is where an IABP fails and causes no mortality benefits. And that's why when we decide to put an IABP late, our results are not so good. So maybe a pre-shock condition or a high probability of reversible shock is where an IABP should be put first, and provided we are taking an early decision within 70 to 80 minutes of the shock happening and seeing the high rising lactate and the lactate clearance being more than 10%, that we should put an IABP. I would put an Impella when I personally feel, again, there is a reversible place of a shock. It's a very costly modality. None of you mentioned that Impella, the downside is RP Impella is something like $25,000, and the use of Impella 5.5 is which amounts to 15 lakhs, and 5.5 is amounting to 70 lakhs. So whereas Tandem Heart and HeartMate 3 are very, very 25 lakhs, within 25 lakhs, you have a modality which will give survival benefits, but which can be used only with a surgical cut down of the axillary of femoral artery. That's the Impella 5.5. And where would you use a cardiogenic shock with cardiac arrest? Only one modality you'll use, and that's a veno-arterial ECMO. So ECMO has a role. It's transient, it's temporary. It can be put in a rest situation where an Impella and a IABP cannot be put. But VA ECMO with Impella together, the Ecpella is where I see the LVADs happening and being put in the right conditions. So this is according to the latest guidelines today.
Thank you, Dr. Poonam M, for your participation and comments. And we are grateful to you.
You are an ECMO person, sir, and also an IABP. I would want you to give your expert comments on what would you prefer to use, since Narayana has been putting LVADs for a long time and also ECMO. Have you used
The thing is, I was telling my the presenters today that for one cost of Impella, you can put 40 to 50 IABPs.
Agreed.
And save so many patients.
Totally
So the cost is an important factor, as you correctly pointed out. With that, we'll move on to the last.
Also, hemorrhage,
Yes.
which we don't see with IABP. Thank you, sir. Thank you.
Yes. Bleeding and hemolysis is a significant problem with the Impella. So we'll move on to the last session. Do we have time, clearing it?
Yes, sir. You can continue, sir.
Another 15 minutes, we'll finish.
Yes, sir. Definitely, sir. Please.
Thank you so much. Now I will call upon Dr. Raghu to discuss about the use of Dobutamine tubes and the bronchial blockers in minimally invasive cardiac surgery. One lung ventilation forms an important component of management of these patients, and Raghu and his team, which includes Dr. Jean and Dr. Alluri Soujanya, they will discuss about the advantages, pro and con of blockers versus Dobutamine tubes. Dr. Raghu?
Good evening, sir.
Good evening.
Hello.
Good evening.
Good evening. Without much wastage of time, we'll start our session. Use of Dobutamine tube or blocker in minimally invasive cardiac surgery, which has grown so much for a period of 10 years. So we'll just start with the use of DLT by Jean. Jean.
Dr. Jean.
Good evening, everyone. Myself, Dr. Jean. I'll be talking about the advantages of Dobutamine tube. Double lumen tubes are essentially two single lumen tubes of unequal length, which are bonded together, and they are designated as either right-sided double lumen tube or left-sided double lumen tube. There are different types that include Carlins, which is a left-sided double lumen tube with a Karanian hook. White, it's a right-sided Carlins tube. Blythe-Smith, which doesn't have any hook. Robert Schultz, which we commonly use these days. It is either right-sided double lumen tube or left-sided double lumen tube. The available sizes are 41 French, 39, 37, 35, 28, and 26. It has two luminas or curve, one terminating in the trachea, the other one terminating in the mainstem bronchus. So coming to the advantages of double lumen tube, the study conducted by Madhu Swami et al., choosing a lung isolation device for thoracic surgery, a randomized trial, they found that it took only lesser time when compared to the bronchial blocker to place a double lumen tube. And all the studies are pointing towards that it's easier to place a double lumen tube, lesser time for repositioning, and lesser number of reposition attempts during the surgical procedure. And apart from that, they found that during the procedures such as pneumonectomy or sleeve resection of bronchial mass, double lumen tube provided much more better surgical field exposure. The second main point is a better lung isolation. A study conducted by Lingya, they found that it was a study between the bronchial blocker and double lumen tube for patients who are undergoing lung dissection. So they found that there's increased lung infiltrate and prolonged recovery period in a bronchial blocker group. And a study conducted, which is showing Obaid and et al., showed that double lumen tube has much more better lung isolation when compared to the bronchial blocker. So one of the major complications of one lung ventilation is hypoxemia, and CPAP applying to the non-dependent lung is a management for that. Double lumen tube allows us to apply CPAP to the non-dependent lung. During massive hemolysis and all, double lumen tube helps in suctioning the lungs individually and thereby protecting the contralateral lung. So in general, the advantages of double lumen tube are, it is relatively easy to place It allows a conversion back and forth from one lung ventilation to two lung ventilation. It helps in suctioning of both lungs individually. It helps to apply CPAP to the non-dependent lung. It allows us to apply PEEP to the dependent lung. It helps to ventilate around the scope in the tube. If there is more rapid lung collapse as compared with the bronchial blocker, it is less likely to be displaced as compared with a bronchial blocker and is the best isolation device. Thank you.
Can we go on to Soujanya?
Good evening, everyone. First of all, I would like to thank Dr. Muralidhar sir and Dr. Raghu sir for giving me this opportunity to take part in this webinar, Pro-Con session. Today, I will be talking about bronchial blockers for lung isolation in minimally invasive cardiac surgery. These are the various types of bronchial blockers that we frequently use in our OR in minimally invasive cardiac surgery for lung isolation. The first one we are seeing is ARNT blocker. The second one is Cohen blocker. The third one is Uni blocker. And the fourth one, which have two cuffs and two lumens, is the EZ blocker. As we are seeing in the picture showing on the left side, bronchial blocker is a catheter with a bronchial cuff at the tip with a pilot balloon. So when we pass this bronchial blocker into one of the main bronchus and when we inflate the cuff, the consecutive lung will be isolated. This is a randomized controlled trial which has been done on 60 patients who are undergoing minimally invasive cardiac surgery. This is to compare the therapeutic value of a bronchial blocker with that of a double lumen tube, particularly in minimally invasive cardiac surgeries. The following slides will be showing what are all the parameters that they have measured in this study and what are all the derivatives that they have derived through their statistics. Airway injury. It has been reported that in bronchial blocker group, there is associated very low incidence of airway injury and trauma when compared to double lumen bronchial isolation group. So a Y-shaped bronchial blocker is far easier for a one lung ventilation and causes less injury and sore throat than a double lumen tube. Consistent with these findings, other studies also found that the incidence of sore throat and hoarseness were both significantly lower in patients for whom a bronchial blocker was used for lung isolation when compared to a double lumen tube. Hemodynamic response to intubation. Mean arterial pressure and heart rate were recorded during intubation, but these were significantly lower when we use a bronchial blocker for lung isolation than in double lumen tube for tracheal intubation. The relatively small changes of mean arterial pressure and heart rate when compared to the baseline patient values indicate that bronchial blocker can be safely applied to the patients undergoing cardiac surgery because this will cause minimum hemodynamic response to intubation. Time to intubate and localize. Although the intubation time and tube localization time in group bronchial blockers were significantly longer than those of group double lumen tubes, they have found that if we place a double lumen tube, but to maintain a postoperative mechanical ventilation after the minimally invasive cardiac surgery, this has to be replaced by a single lumen ET tube. But patients receiving a bronchial blocker, they just need to pull out the bronchial occluder from the single lumen tube and connect directly to the postoperative mechanical ventilation. So this time is nullified there. Airway pressures. The airway pressure when we use a bronchial blocker is significantly lower than that of a double lumen tube after commencing single lung ventilation. This small airway resistance favors the redistribution of pulmonary blood flow to the ventilated lung more, thus relieving the intrapulmonary shunting which happens in one lung ventilation. So this in turn improves the oxygenation during single lung ventilation. This carries very high significance, particularly in minimally invasive cardiac surgery when the patient is put on cardiopulmonary bypass. PaO2 and FiO2. Single lung ventilation can drastically reduce PaO2 FiO2 by 60 to 70% than baseline in minimally invasive cardiac surgery. But This study showed that there is significantly higher SpO2 and PaO2 values in bronchial blocker group when compared to WMN tube after commencing of the cardiopulmonary bypass. This result may be explained by the fact that application of bronchial blocker can relieve the systemic inflammatory response on pulmonary function after commencing cardiopulmonary bypass. Treating hypoxia during one lung ventilation in bronchial blocker group. So there is an additional advantage to connect a continuous positive airway pressure mainly to the suction port of the bronchial blocker to overcome any hypoxemia that is caused after commencing one lung ventilation, particularly considering when the patient is coming off bypass or after weaning from bypass. Bronchial blockers are mainly indicated in difficult airway scenario. Why? When we are going to assess a patient airway, when the airway is already anticipated to be difficult, WMN tubes are relatively contraindicated for lung isolation in view of possibility of significant airway trauma and inability to secure the airway. This is secondary to larger diameter of WMN tube when compared to conventional ET tube, which makes it very difficult to manipulate with laryngoscopy in difficult airways or tracheobronchial malanatomy or disruption or when the vision is obscured. These situations always necessitate the use of bronchial blocker to isolate the lung. These are few images which show the morbid airway injuries which happened when we use a WMN tube in some of the case reports. So WMN tube is relatively contraindicated when a patient airway is anticipated to be difficult. In the left corner of the picture, we can see a tracheal ulceration and tracheal edema following above the level of the carina following a placement of WMN tube. And in the right-sided picture, we can see a crater-like ulceration which is formed above the carina after using WMN tube for lung isolation. This is a case report which showed bronchial rupture after using a left-sided polyvinyl chloride WMN tube for lung isolation. So bronchial rupture carries the greatest morbidity and mortality and one of the deadliest complications of WMN tube intubation. DLT is also associated with patient size mismatch which can be overcome by bronchial blocker. So when there is a patient size mismatch, this often leads to multiple laryngoscopic attempts and exchanging different DLT tubes which causes significant airway trauma, edema, postoperative sore throat, postoperative ventilatory complications. Why we find difficulty in selecting appropriate size of DLT in certain situations? Most common we come across are short stature patients, morbidly obese, pediatric age group, any skeletal disorders, and DLT also come with limited sizes like 28, 35, 37, 39, and 41 French. So in all these difficult type of scenarios, and when there is an anticipated patient size mismatch, DLT will give a serious threat for multiple laryngoscopic attempts. So we can prefer bronchial blockers in this situation. This is one of the most commonest complication that we see using a DLT is bronchial cuff tear. This requires again reincision of another DLT, which is difficult in the mid of the procedure, which causes high chances of hypoxia and hemodynamic stability, especially in minimally invasive cardiac surgery. But again in this scenario, bronchial blocker can come to your rescue. How? There are few case reports which state that bronchial blocker can be directly passed through the bronchial lumen of the WMN tube for lung isolation in a rescue event without the need for reintubation. This is another case report which showed inadequate lung isolation in a patient with very short right main bronchus with WMN tube. Most of the patients have a straight right main bronchus which is more than 18 mm, but in 10% of the patient population, the right main bronchus is less than 10 mm, and in 2% of the patients, the right upper lobe orifice will arise directly at the level or above the level of carina. In these two types of situations, WMN tube lung isolation will not work because it will lead to inadequate lung isolation and we will end up ventilating the right upper lobe. This is another case report stating successful passage of bronchial blocker in a patient with very limited mouth opening, where they have failed to isolate the lung by using a DLT. After 2-3 attempts of using DLT, they have chosen bronchial blocker placement using nasal approach for lung isolation in a patient undergoing pneumonectomy and minimally invasive cardiac surgery. So these are all the pros of bronchial blockers when compared to the double lumen tube. So all these case reports, all these studies have shown that bronchial blocker is very efficient method for lung isolation, which causes significantly less or null complications when compared to the double lumen tube. Thank you very much.
Thank you, Soujanya. I thank Jean and Soujanya for their excellent presentation. Actually, in the clinical scenario for our cases, we are using a bronchial blocker for almost all the cases. Suppose wherever the cases where we do thoracoabdominal cases, in such cases, we are placing a double lumen tube because those cases, the whole lung is isolated for a long time and the surgeon is comfortable with having a complete lung collapse with only double lumen tube, not with the blocker. Rest of all the cases, we are using a bronchial blocker. One of the thing I just wanted to highlight, as this both speakers explained, the bronchial blocker is available in a single size, which is easy to select. But in a double lumen tube, we have to select the appropriate size and we have to position it properly. And in the lateral position, it is very difficult to address the problem with a double lumen tube than with a blocker. Even if the blocker displaces in lateral position, it can be placed easily and we can overcome the problem and we can have an adequate collapse at the during the surgery or intraoperatively. So I believe bronchial blocker is just invasive adult cardiac surgery because we don't have the pediatric, particularly in our institute, we are having a
Raghu, your audio is off.
adult.
Yeah, now it's good.
Hello.
Yes, yes.
Sir, over to you. Want anything, sir?
No, that's fine. Thank you so much. Thank you, Raghu, for joining us. And
thank you.
Both Jean and Soujanya have done a good job of describing the role of double lumen tubes and bronchial blockers in minimally invasive cardiac surgery, which we do routinely. We do about 4 to 6 cases every day that this minimally invasive cardiac surgery. And with this, I would like to thank all the participants, Dr. Rajesh Arya moderating Pavithra and Satish, Selva Kumar moderating the discussion on Dobutamine and Milrinone, then Kumar moderating the discussion on PAC and TEE, then Kanagarajan moderating on-pump versus off-pump, Dr. Poonam M moderating IABP versus Impella, and Dr. Raghu moderating the discussion on double lumen tubes and bronchial blockers in cardiac surgery. With that, I would like to request Dr. Jayashree Sood to propose a vote of thanks.
Good evening, everybody. What a webinar we had today. Thank you very much. Dr. Murli, of course, has thanked all the moderators. Thank you very much from our side as well. Of course, he's one of the very senior members of our ICA and the National Dean. But on behalf of the other office bearers, I would like to thank you all. And it was an excellent webinar moderated by all of you. And the talks by each and every speaker was excellent. We learned a lot and we didn't realize actually the time passing by. Thank you so much, Dr. Rajesh, Selva, Dr. Kumar, Dr. Natarajan, Poonam, and Dr. Raghu, and the speakers as well. Dr. Pavithra, Satish, Karishma, Preethi, Meera, Elizabeth, Madhu, Nishant, Dr. Sahoo, Syed, Dr. Philip, and Dr. Soujanya. Thank you so much. And we'll be seeing you all very soon in one of our next webinars, all on the cardiac, as Dr. Murlidhar is an expert in that. Thank you very much. Thanks, Dr. Murli. And thank you, Sanish and Shweta. Thank you very much. Good night.
Good night and thank you so much. Thanks for joining us.
Thank you so much. Good night to all.
Thank you. Thanks a lot.
Yes, thank you, sir. Thank you.
Thank you.